So today I'm going to talk with you guys a little bit about back pain. And this is something that's not only important for your patients, but is actually probably important for everybody in this room. Because back pain affects about 65 million Americans every year. 80% of us and everybody will experience an episode of low back pain in their lifetime. Now, fortunately, this back pain will probably be acute, and that means it's going to resolve in an order of weeks or months, and it will resolve spontaneously, meaning we don't need to do any further intervention for this. But of that population, 50% of people who have a low back pain will go on to have chronic low back pain. So back pain is really classified into two different types. There's the acute low back pain, which is again what most people are going to have in their lifetime. And that's a sudden, intense pain. And again, it usually resolves in a course of a few days to a few weeks. But of people who have acute low back pain, 5 to 10% will go on to have chronic low back pain. And this chronic low back pain is something that as healthcare providers, we sometimes struggle with identifying and treating appropriately. So let's dive into a little bit about where back pain comes from. And that usually starts off with reviewing the anatomy. So the spine itself is broken up into 4 different categories: the cervical, thoracic, lumbar, and sacral regions. But the spine itself is actually quite complex. There's many structures in there that make it work appropriately and help you walk and function. And those structures can all have problems throughout our lifetime that can cause nerve pinching, that can cause back pain. So there are things like your nerves that come through your neural foramen. It can be pinched there. There are your joints in the back. Those can cause pain. There are your discs in the front. Those can degenerate or have pain themselves. And then there are the ligaments and support structures that give extra support to both the discs and the joints. And then you have your muscles that are behind here that also help to support your spine. So looking at the spine in a cross-section view, we see that the nerves in the spinal cord are in the center, but these nerves in the spinal cord have to leave to go down to your legs and your arms. Now, as they leave, they pass by the joint and they pass by the disc. So if there's a problem with the disc or the joint, that can affect the nerve. It can pinch the nerve and cause pain. Likewise, inside the center canal, there's also ligaments that help to support the nerves. These ligaments, the ligamentum flavum and that posterior longitudinal ligament, live inside the canal. So if these thicken or increase in size over time, these can also pinch the nerves. So the back itself is a complex structure, and there are many places that pain can come from. When it comes to nerves coming out of the spine, they go to your arms and your legs, and these really can give you signals to where the pain is coming from in the spine. So for example, if a patient is having a problem or pain in their big toe, you may be thinking there could be an issue with the L5 nerve root. So it's important to remember your dermatomes and where the nerves go, because that can really give us clues to where there could be a problem in the spine. So that's a review of the overall structure of the spine. How do we work this up? How do we figure out where that pain is coming from? Well, that really goes back to a good history and physical. What are some of those things that you want to ask a patient who comes to you and says, I have back pain? Well, you really want to go back to the PQRST acronym that we learned in school, right? What is the provocative palliative factors that affects the pain? Are there things that make it better or worse? Are there activities that make it better or worse? And this is important. You know, is the patient able to run but they can't stand? Are they able to bike but they can't lay flat? Other things are like the quality. What does it feel like to the patient? Is it sharp? Is it stabbing? And what's the radiation? Where does it go? Which nerve roots is it affecting? The severity, how greatly does this impact the activities of daily living? If someone comes to you with back pain and they say, you know, I have it once every year, it's a 1 out of 10, that may not be worth escalating your diagnostics. That may not be worth escalating your treatment plan. But if their pain is a 10 out of 10, you may want to be a little bit more expeditious with your workup of that patient. And then time, when did it start? Are we dealing with a low back acute pain episode, or are we dealing with a chronic back pain issue? So, my back hurts, just do surgery and fix it. I'm sure all of you have heard this. But even though we may want you to believe this, surgery is not always the right answer. So, what are some of the causes of pain? So first and foremost, the most common issue with pain is degeneration, and I'm going to talk a little bit more in depth about degeneration. There are other things that can cause pain, again, changing that structure of the spine where the nerves are, and those are things like deformity, trauma, infection, invading the bones or the discs, tumor, again, there being a mass where there's not supposed to be in the spine, and then inflammation, the nerves being irritated or inflamed. So, what's the epidemiology of degeneration? Where does it come from? Again, this is one of the most common causes of pain. So, physical loading forces, or the life that a person has already lived, plays a huge role in degeneration. And it's not necessarily anything that we would change, but there are certain activities or occupational hazards that can put extra stress and strain on those discs and those ligaments. These are things like high velocity rotational activities, golf, tennis, racquetball. Our farmers that are tossing hay bales, or people that are out there shoveling snow all the time. That can be a high velocity rotational force on the spine. And other things like running or jumping, pounding on those discs. Now, genetics or hereditary plays a huge role as well, and we can't change that. Degenerative changes in women tend to come a little bit later in life than they do in men. And nicotine is a huge component of disc degeneration. In fact, many of our surgeons won't even operate on people that use nicotine, and we do blood tests to prove that our patients aren't using nicotine. And then other things that can lead to degeneration in the spine are things like osteoporosis, and I'll talk a little bit more about that, and rheumatoid arthritis. They can change the strength and stability of the bone and give other causes for deformities. Now, some of the other things that can cause back pain are muscle strains. And actually, muscle strains is the most common, or the majority of what back pain comes from. So you're out doing yard work, you strain your muscle. Now, this will heal with conservative therapy and time. It does not necessarily heal with surgery. So time can be a big factor in letting your back heal. Other common spinal problems that we'll see are issues that, again, relate to the structure of the spine not being appropriately aligned. So things like irritated nerves, inflamed joints in the back, herniated discs, ligaments, and bones. Now, herniated discs are actually present in up to one-third of all adults over the age of 20. A lot of you in this room probably have herniated discs. I may have a herniated disc, and I may not even know. So not all herniated discs are symptomatic. Other things that can cause pain are facet joint arthritis. That joint is not functioning the way that it should, so therefore it's causing extra pain on those nerves. There's spinal stenosis, or pinching of the nerves in the center. There's degenerative disc disease. There's degenerative disc disease. So you can see here, this is the normal height of a disc here, or here. And here, that disc has kind of been compressed over time. There are bone spurs and other ligaments that thicken that can cause this area not to function the way it should. When it doesn't function the way it should, it can have edema or swelling within the bone, and it can also cause the nerve hole height, where the nerve comes out, to shorten. That shortening can compress that nerve and then cause pain. And then there's spondylolisthesis, or a slipping within the spine, that can also compress the nerves as well. So herniated discs, we talked a little bit about that. Again, they can be present in people and be asymptomatic, but compression can also result in severe radiating pain that goes down their leg, or weakness, or numbness, or tingling. And this is where that radiculopathy really can come into play. As you can see here, the nerve is being pinched right here as it comes out of the spinal canal between the bone and the disc is pushing the nerve out of place. Now, 90% of these will occur at L4-5 or L5S1. It's the most common place to have a herniated disc in the spine. Now, here are some radiological examples of what herniated discs look like. Over here, you can see that the disc is protruding and the joint is enlarged, and there's not a lot of white space for that nerve to get out. So this would be compression of the nerve from a herniated disc. Here is a side view, or a sagittal view, of the patient's spine that shows a bone spur, and again, that shortening of that canal, or invasion of that canal, from other spinal structures. This is normally what we would want the height of that neural foramen to look like on an MRI. So lumbar stenosis, a little different than herniated discs, but kind of a similar concept. There is invasion of the space where the nerves live. So the nerves are being pinched off. Now, this can be a normal progression of aging. The discs can degenerate with time, ligaments can thicken with time. And not all spinal stenosis is necessarily surgical. It's not all symptomatic. It's not uncommon that we'll have a patient come into our office referred by their primary care doctor because they've got spinal stenosis, and they say, I'm supposed to have surgery, this is what my MRI shows. But if that patient is asymptomatic, We give them warning signs and things to watch out for, but we tell them to call us when they need us. That doesn't necessarily mean they need to be rushed off to surgery. Now, lumbar stenosis, when it does become symptomatic, can produce something called neurogenic claudication. And classically, neurogenic claudication is one of the signs of it is called a shopping cart sign. So you have the old lady that cannot stand up straight, but when she's in the grocery store, leaning over her shopping cart or her walker, she's fine. And the reason this is because there's a ligament in the back of the spine called the ligamentum flavum, and when you bend forward, that ligament flattens out. And then when you stand up, that ligament buckles in. So that few millimeters of buckling in of that ligament actually increases that spinal stenosis, that narrowing, and causes pain. Now, I don't necessarily see a lot of the shopping cart sign here in Boulder. What I do see is people who say, oh, I can ride my bike 100 miles, but I can't walk up Sanitas anymore, right? So these are other questions that are important to ask patients. What can and can you not do in your normal life? So deformity is another cause that can lead to back pain, and scoliosis and spondylolisthesis are two of the more common deformities that we'll see. This here, you can see that the spine is curving over, and this not only affects the pinched nerves, but this causes an unequal distribution of forces on those discs and those joints. So you may have a disc or a joint that's having more force on it than it should, because the spine is kind of over to one side. It also affects your muscles. So when you have a scoliosis like this, one of your muscles is elongated and the other one is shortened. So the overall musculature of the spine is also not in that in the correct anatomical position. And then there's spondylolistheses. So you can see here, these two bones are lined up perfectly in the back. So this nerve canal is nice and tall, plenty of room for that happy nerve to be. And then down here, this neuroforamen is stretched. These joints are stretched because this bone is slid on top of this bone. So this would be an example of a deformity, again, that can create some nerve pain. Now, we've talked about some of the causes of pain. What are some of the structural things that can cause pain? How do we treat it? What do we do when someone's complaining of back pain? Well, one of the first line things we do is we recommend physical therapy for people. And this is actually the thing that keeps people out of our office the most, is physical therapy, okay? And they do a lot of wonderful things for patients. It's not just strengthening those muscles that support the discs and ligaments. It's also heat, massage, increasing blood flow to the area, like doing dry needling or ultrasound. So physical therapy is really a great thing that can help support the structure of the spine to take off those unequal forces and the stress that it's feeling. And then there's activity modification. Now this is something that nobody wants to do. Nobody wants to give up golf. Nobody wants to give up tennis. But we're not saying in the long term that you need to do those things. But if you're having really bad low back pain, take a break from the things that exacerbate it. And those are things we talked about before that are those high rotational forces, like golf, tennis, racquetball, and those types of things. Other things that can be beneficial to help with back pain are chiropractic care. Now, chiropractic care can be great, but it's not going to take a scoliosis and make the spine look like it's a textbook spine. So it's always something to consider. There's acupuncture, which helps promote blood flow to the area. Inversion or decompression tables. Those are great, but unfortunately we live in a world with gravity and everybody has to stand up eventually. And then there's things like weight control, really narrowing down that central obesity that can pull that spine forward out of alignment, and time. Time is one of the most important things we can tell patients to have. And it's one of the most frustrating things for both the provider and the patient, because there's not often sometimes things we can do to make nerves heal faster. And nerves heal over a course of weeks to months, not days. So those are some of the modalities. What are some of the medications that we can try for patients? Well, there are things like Tylenol and nonsteroidal anti-inflammatories. If you're going to recommend a nonsteroidal anti-inflammatory, make sure it's a good anti-inflammatory dose, like 600 to 800 milligrams of ibuprofen. There are also traditional steroids like Medrol dose packs and prednisone bursts, and I honestly really like Medrol dose packs for patients that come in with an acute low back pain episode that are having issues that are related to inflammation. There are muscle relaxers, again, like anti-inflammatories, treating the source of pain, right? Treating that muscle problem. But avoid things that are benzodiazepines like Valium or Soma. These are sedating and can be addicting for people. So try to stick to the non-sedating, non-addicting ones. And then referral to physiatry to talk about interventional injections. Now, I'm not going to go into interventional injections too much. I know we're going to have another talk about that a little bit later on. But I just wanted to briefly show you the difference between different types of injections we can order for patients. So injections are usually a combination of steroid and numbing medication. And this is not only helpful for the patient from a therapeutic benefit, but is also very diagnostic for us. When we're thinking about doing surgery on a patient, we want to make sure that we recommend the right surgical procedure. Is that patient a candidate for a decompression? Are they a candidate for a fusion? Where is their pain coming from? Because dependent on where their pain is coming from, that makes a difference with what we have to treat surgically. So this here is an epidural injection. This is where medication is put right on top of the nerves. In contrast, this is a facet injection. It goes into the joint. So if pain is coming from the joint, it would be more treated with a facet injection, whereas an epidural injection would more target the nerves. So again, pain can be coming from different spots. The spine is not a one-size-fits-all. There are many areas in there that can cause us back pain. So we talked about some of the conservative things that we can do for patients before they get to surgery. But sometimes there are some red flags that should say, okay, I need to consult a surgeon. I need to get this patient in for a higher level of diagnostics. And so these are things like trauma, okay, especially in older people. Is there a structural problem? Is there a history of cancer or unexplained weight loss? Okay, is there some malignancy that's metastasized to the spine? If there's a failure to improve in 4 to 6 weeks, we give patients time to heal. We try conservative things, but if they're not working, we may need to escalate our level of care. And then things that are like quad equina syndrome or are quad equina syndrome, and that would be urinary or fecal retention, or even something like saddle anesthesia. Those nerve roots are being severely compressed, and there's a risk of the patient having permanent loss of bowel or bladder control. So some other red flags that we worry about with patients are things like persistent fevers or things that make us think, is there an infection in the spine? Like immunosuppressants or anybody that's had a recent infection, a UTI, a pneumonia, or even a dental abscess. Those things, that bacteria can get into your bloodstream and travel to your spine and cause an infection. So what are some of the absolute and relative indications for a patient going on to have surgery? So the absolute ones are progressive motor deficits and quad equina syndrome. But the relative ones really are a discussion between the surgeon and the patient. Those are failure to improve with conservative treatments, severe pain. If the patient's in a 10 out of 10 pain, they may not be able to do physical therapy. And so it's important to talk with them about that. Large extruded disc fragments, a free-floating disc fragment, that may be another reason to consider surgery if there's a large compressive force there. And then people that don't get better with conservative treatment in the long term. So if someone comes to you in the spring and they're having low back pain, and you give them Medrol dose pack, they do PT, they do fine, but then they're coming back to you in July, and then they're coming back to you again in August, and then they're coming back to you again in October, they may need more than conservative treatment. So what are some of the surgical options that we talk about with patients? Well, they really fall into kind of 3 main categories. One are the decompressions. These are microdiscectomies, laminectomies. This is usually where we're removing a small portion of bone to unpinch a nerve or to remove a small piece of disc. Now, we are limited with the amount of bone and disc we can remove from patients when we do discectomies and laminectomies. And oftentimes, if we need to remove a lot of bone or a lot of disc and we would destabilize the spine, that's when we start to talk about fusions. Fusions allow us to do a very robust decompression. We can remove the entire joint because we know that we're going to go back in and restabilize the spine with hardware. But also, fusions are indicated in people who have a joint problem, right? So again, going back to those diagnostics, that injection. If your patient gets great relief with a facet injection, they're likely not going to get better with doing a small decompression. But all patients that come into our office talk about having minimally invasive procedures, avoiding fusions. But sometimes that's the best option. And we'll talk in a little bit how we've gone to more minimally invasive approaches when it comes to fusions. And then there are things like motion preservation. There are disc replacements. You have to be the perfect candidate. You have to have good motion within your spine to be a disc replacement candidate. And then there are other alternatives that are coming on the market, like the Limi Flex, and this is an FDA trial that our practice is currently involved in that I'll chat about in a little bit. So what are some of the other trends in spinal surgery? We've talked a little bit about them. Every patient wants a minimally invasive surgery. Every patient wants to preserve their motion. And there's also things that help us along the way, and those are things like biologics. If we do a fusion on a patient, we no longer have to harvest satellite bone. We can use their local bone or use cadaver bone for that. And there are things we use to improve our safety and our efficacy during surgery, and those are things like computer navigation and neuromonitoring. So let's talk a little bit about some of these procedures. This here is a diagram of a microdiscectomy, and this is, one of the most minimally invasive microdiscectomies we can do, which is an endoscopic microdiscectomy. The patients usually recover quite quickly from this, and there's pretty good results. So about 85 to 95% of people will have a good short-term result with this. However, the degenerative processes of the spine are still in place. Your joints are still going to move. Your disc is still going to have wear and tear on it. So long-term results with decompressions are usually only about 55 to 70%. And the average length of time that a decompression can last a patient is only about 4 to 5 years. So having a talk with the patient about good spine health, really restoring some of those corrective issues that are irritating the spine, like lifestyle modifications, physical therapy, and again, just having good overall back health is really important. Then there's spinal fusions, right? And spinal fusions can be multi-level, they can be two-level, but it's something where, again, we can really remove that bone and decompress those nerves and treat facet joint pain. Now, spinal fusions have come a long way, and we're often using minimally invasive techniques to do them, but these are great to help to restore spinal stability, either because the patient had an unstable spine when they came in, or because they've got we've destabilized it by doing surgery and removing the bone. It can also help to correct deformity. So if a patient has a scoliosis, we can actually move the spine back a few degrees in order to realign it. Now, spinal fusions, again, in the past were usually always recommended for any type of deformity, and especially when a patient had spondylolisthesis. But there is a new device called a Limi Flex that our practice is undergoing an investigational trial for. And I'm not going to go into this into too much detail other than the fact that we are always coming up with new devices to help patients to kind of be on the forefront of surgical options for patients. And what the Limi Flex is this is a paraspinous tension band. So if a patient has a spondylolisthesis in the past and they only had leg pain with a minimal amount of back pain, we would say, I know leg pain, a nerve pinch problem is what's going on. But when we go in there and we do surgery, we may destabilize your spine because it's already slipped. And by removing some of those structures in the back, that slip may increase. So we're going to have to do a fusion. Well, the Limi Flex is a little bit of an alternative to that. So this is indicated for patients that have a grade 1 spondylolisthesis, only 10 to 25% of the slip. And what we do during surgery is we go in and we decompress the nerves up to 2 levels. 1 level slip, and then if there's nerve pinching going on at an adjacent level. And then we put that spring that I showed you in the last slide on either side of the spinous process, and then a tension band to help support that level. So again, this is just another alternative to helping with, to help stabilize the spine in a setting of a spondylolisthesis when the patient only really has radicular pain. Now, there's some exclusion criteria that make people not candidates for Limi Flex. And these are good things because these are often reasons that the surgery wouldn't be beneficial for them. That's discogenic back pain. If we stabilize the spondylolisthesis and the disc is the problem, we're not touching the disc. They're still going to have problems. Facet-mediated back pain. Again, fusion is a good treatment for facet-mediated back pain. And then back pain that doesn't make any sense. We send patients for an injection and they don't get any relief. Their pain may not be coming from the level that has a slip on their MRI. So we talked about fusions and how oftentimes that's what patients want to avoid, but we've done a lot of things in recent years to make them more minimally invasive, to make the recovery faster. And this really kind of goes back to things that relate to our computer navigation, because these help us place screws the right time, the first time, right? They also allow us to go back and check our screws into more of a three-dimensional model after they've been placed. And because we're getting a view of the spine that we wouldn't have just by looking down with a microscope on top of the spine, it allows us to do less muscle trauma and more minimal incisions. And for all the healthcare workers in here, it's great because we can spin an O-arm on a patient in 13 seconds. That's 13 seconds of radiation, where at most places you can leave the room. This is reducing our risk of radiation, which is great. And so this next slide here is just a picture of the O-arm and what it looks like for those of you who don't work in the OR. So we place the patient on the operating room table, and then we bring in a CAT scan that's open. Then we close it, and we attach a stereotactic frame to the patient. This allows us to see our instruments in almost a 3D model. So we can see the screw going across the pedicle directly into the spine. we don't have to worry about being off a couple millimeters and hitting the nerve. So it really increases our efficacy. This here is a spin of a patient after we've already placed the screws. Again, in the operating room, we can confirm that that screw is across that pedicle. And look how narrow this is. You can imagine it's hard to place that if you can't directly see that going through there. And even now we have navigated cages. So again, we can watch that cage go into the disc space and make sure that it's in a good position and not out here in front of the spine. So now I'm going to switch gears and talk about something that leads to deformity within the spine, and that's osteoporosis. And the reason I'm going to talk a little bit about this is it's actually a really common problem that people are not even treating yet. And in fact, there are 700,000 vertebral fractures a year. And 75% of women, which is the majority of us here, right, haven't even talked to our providers about their bone health. And so it's really important that we start talking about it. So I'm going to talk a little bit about it today. So there's some risk factors for osteoporotic fractures that are completely out of our control. Family history, having a small frame, being female, can't change that one really. There's postmenopausal, and there are treatments, long-term treatments like steroids. Now there are modifiable risk factors that we can educate our patients about: smoking, increasing nutrition, lifelong calcium or low sun exposure, and excessive alcohol and caffeine intake. So I should watch how many coffees I've had this morning. So what are some of the medical management that we can do for patients, right? What are some of the things that we can recommend to prevent these osteoporotic fractures from happening? Well, there's the baseline calcium and vitamin D, but then there are also other medications like bisphosphonates. And bisphosphonates are the traditional osteoporotic medications. Now the problem with these is they prevent osteoclast activity. So they prevent that bone from breaking down. They don't build new bone. And Prolia is similar to the bisphosphonates, and it helps with bone reabsorption to prevent that. It also helps from the bone breaking down. But there are two newer agents on the market. There's Forteo and there's Tymlos. And Forteo's been around a little bit longer than Tymlos. These are parathyroid analogs. So this increases the parathyroid hormone activity in your body and will increase that osteoblastic activity. Now, the downside to that is you can have increased blood levels of calcium, which can also be dangerous for your heart. And so that's why they're coming up with newer agents like Tymlos, which has a less potential for increasing blood calcium levels. And then other things that can help are things like estrogen or androgen therapies. Hormones can really play a huge role in bone loss. And then regular weight-bearing exercises. So then we talk about some of the symptoms that osteoporotic fractures can have. There's pain, localized pain right on the spine. So this is someone where you touch their spinous processes and they say, ow, this hurts. They can also develop poor posture, right? All should sit up straight. But it also can reduce your height over time. And then this can lead to kyphosis, which can lead to a structural issue, which can lead to nerve pinching, which can lead to chronic pain. And with these people already having soft bones, there are a lot of surgical options that may not be good for them. So the most common locations of vertebral fractures are in the mid-thoracic range. We all bend forward at that T7, T8, and then at the thoracolumbar juncture at the T12 to L1, because again, that's a huge fulcrum point for our spine, where our ribs and sternum stop and our lumbar spine becomes more mobile. Now the treatment options really kind of fall into two main categories. There's the conservative and the surgical, just like we talked about with pinched nerves. But the conservative management necessarily isn't always the best route, or the surgical. You really have to look at your individual patient. So bed rest used to be often recommended for compression fractures, but that has its downsides. That can lead to further bone loss because they're not doing that weight-bearing activity. It can also lead to things like pneumonia, blood clots, deconditioning, decreased muscle mass. And so bed rest is not a great option. There's medicines like narcotics, but we all know those are not great in our elderly population, or NSAIDs, but there are some studies that show that NSAIDs reduce bone healing, and we're trying to heal bones. Braces, such as the one that you see here, this is the Jewett brace that we often will put our patients in for compression fractures in the lower thoracic or upper lumbar spine, and these can prevent those fracture fragments from grinding around and stabilize it so it can heal. But fractures can take 6 to 12 weeks to heal with conservative treatment. That's 6 to 12 weeks of being in a brace for some patients, and maybe even longer depending on their bone health. So then we talk about surgical options, and those are things like minimally invasive surgeries like kyphoplasties and open options. So kyphoplasty can be performed under local anesthesia, light sedation, or general anesthesia. as a neurosurgery practice, we typically will do these underneath general anesthesia so the patient's not wiggling around when we're so close to their spinal cord. There's a low complication rate, but it's not a 0% complication rate. There's the risks of anesthesia, which again our older patients may not tolerate. And there's also the risk of cement going in places that it shouldn't go. So the complication rate isn't 0, and you really again have to weigh those based on the patient. But there's usually pretty good relief of that back pain in 24 to 48 hours if the compression fracture is the source of pain. So we've talked a little bit about back pain. Let's talk about some scenarios. So here you have a 55-year-old male with no past medical history at all. He comes into your clinic with low back pain after mowing the lawn 5 days ago. If you assume that his exam is completely normal, other than some decreased sensation over his anterior foot, what would be your first recommendation for the patient? Would it be telling him, just push through, you'll be fine? Would you do a medral dose pack with activity modification and tell him to try PT for 4 to 6 weeks? Would you order a stat MRI because he's in pain now and he wants an answer? Or would you immediately refer him to surgery? B, awesome. Good job, guys. Here's a picture of this patient's MRI, okay? So he did not improve with 4 to 6 weeks of physical therapy, and it shows that he has a left-sided L4-5 disc herniation. So that explains why he's got that decreased sensation over his left great toe. Now, decreased sensation doesn't necessarily mean that we're going to rush that patient off to surgery, because numbness is difficult. And sometimes even with surgery, we don't fix numbness. And that's something to kind of educate patients about when you're seeing them, that numbness isn't a reason to rush them to surgery. And even with surgery, sometimes that's the symptom that lasts the longest afterwards or doesn't improve completely. Now, here's another situation. We just talked about osteoporosis, so you guys should all get this right. You have a 72-year-old female who presented to the emergency room with mid-thoracic pain after a fall in her bathroom last night. So the fall just happened. Now, her strength is completely normal, but she has spinal tenderness, and this is what her x-ray showed. So she's got compression fractures at T3, T4, T7, and T8. Are these all the problem? So, given those compression fractures, what would you recommend? Would you get an MRI to evaluate the acuity of the fractures? She fell last night. It could have just happened. Give her narcotics and place her on bed rest? Do a trial of bracing, or tell the patient just to resume all normal activities? A, exactly. We don't know whether these fractures are from that fall or from some other time. So this is what her MRI showed. Only that T8 fracture was acute. All of these other ones were old. Now, she never remembered falling before. I don't know how good of a historian she was. I've only known her for a brief moment. But she says she never fell before. But only this one has edema and swelling on it on the MRI. So if we didn't get the MRI, we may have thought that all 4 of those fractures were acute. We tried bracing with this patient for 3 months. It failed. She went on to have a kyphoplasty, and she's doing great. So hopefully she won't fall anymore, and she'll be doing well. So now we have a 24-year-old female who was recently treated for a UTI. She came into the office with new low back pain, never had it before, and a low-grade fever. What would you want to do for that patient? Would you order a stat MRI? Would you prescribe an anti-inflammatory and tell the patient to follow up for a recheck in 6 weeks? Would you immediately refer her to surgery, or would you put the patient in a brace? So with a fever in the setting of new back pain, it's good to order an MRI, right? If she didn't have the fever, you may try the conservative treatment before ordering the MRI, but she's got a fever. So this is what her MRI showed. So she's got L3-4 osteodiscitis. And we ran some labs on her, and she had an elevated white blood cell count, she had an elevated C-reactive protein, and an elevated ESR. So even though she had these symptoms and she had a fever, that was all she had. Okay, she had no neurological deficits. So what would you do? Would you prescribe her Bactrim? Would you prep the patient for emergency surgery? Would you refer her to infectious disease? Or would you order her a brace? I'm hearing a lot of different answers. So for this, we would actually refer her to infectious disease. So a lot of osteomyelitis and discitis can improve with antibiotics. And there's big risks to going into a patient's spine who's infected. So we can see that on her MRI, she had collapse of her disc space here. Okay? So in order for us to fix that, she would require hardware to restore that deformity. Hardware loves bacteria. We never want to put bacteria, or we never want to put hardware into a patient where it could potentially get infected, because that causes other problems. So if she has a normal neurological exam, we would go ahead and we would refer to infectious disease to start antibiotics. And usually that antibiotic duration is 6 weeks.